you very much for joining in and taking out your time to attend this very important session. We have a wonderful lineup for today. There's a brilliant group of speakers. We'll introduce them as they come. Communication skills is a really important thing particularly for people who are not living in Ireland, who come from foreign backgrounds. I remember my first day in Galway AD. I went in to see this middle-aged gentleman. He was up from Connemara. And I went to him and I asked him, what brings you to the hospital? And he said, I have problems with my waterworks. This was my first day in Galway. And I had absolutely no clue what he meant by problem with my waterworks. And I tried thinking that if water works at his home is not working fine, he should call a plumber. Why is he here in the hospital? I tried figuring it out for a couple of times, and he had a very thick Connemara accent. It was very hard for me to understand him first, and then trying to figure out the waterworks. Anyhow, I went outside and I asked this nurse, who first had a big laugh at me. And then she took me to the corner and she explained me what waterworks means and what this farmer from up Connemara actually means. The poor man was in acute urinary retention. And I couldn't figure it out for the first 10 minutes of my consultation, what he actually means. And this is how important communication skills are. These are little things that we need to know, we need to learn. And particularly when you're coming from a different country, you don't speak the language that people speak. There's so much to learn. And in last 5-6 years, I've learned so much. I thought that I was a brilliant communicator when I came to Ireland. I realized that I had absolutely no clue how to communicate, how to speak to patients, how to break a bad news, how to try and settle down someone who's very angry. So this is really important, isn't it, Adil?
Yeah, I completely agree with Mustafa. When you come, you need to learn how to communicate not only with patients, but your team, your co-regs, your SHOs, your interns. Everyone plays a part. And if you have good, effective communication, at the end of the day, patients come first and you want to make sure that you do the best for them. It's the miscommunication that can lead to delays and things happening. So it is best to do a few communication courses, be able to understand what things want and not be afraid to ask, what do you mean by that? And then go from there.
Indeed. As a surgeon, I'm sure asking for a consent, explaining what exactly, consenting a patient, telling them what it involves, how important it is for the patient to understand what can possibly happen, what am I going through, what, for you going into a medical jargon, I'm going to put in a central line into your neck.
Yeah.
The poor patient has no bloody idea what we're talking about. So you need to be you need to speak the patient's language, be as simple and same goes for your teammates, your interns, your SHOs, your co-registrars, your consultants. It's so important that the importance of communication skills, as much as you can stress it, it is bigger than that. At this point, we've discussed how important communication skills are, and I'm sure you are all waiting for the actual session to start. So I will start here by introducing the person behind the show, who has been an inspiration for junior doctors and trainees like me, Dr. Khalid, who is the founder of Pakistani Professionals Association. He is a consultant in orthopedics with RCSI. He has previously been an assistant professor of orthopedics at Al Khan University Hospital, which is one of the biggest trauma centers in Pakistan. I worked there, I trained there. I know what an amazing place that is, and being a professor there means a lot. Dr. Khalid is also the founder of Foot and Ankle Society in Pakistan, which he founded there with the help of other colleagues. And then he was secretary for Irish Orthopedics Foot and Ankle Society here as well. And he has done a lot to bring all the trainees together. I'm here because of him. And he has provided us with a platform to, to try and inspire the younger doctors coming from Pakistan and other countries to take on, to come forward and take on the training post and to inspire to come up through the proper channel. And it's a wonderful thing that you've done, Dr. Khalid. Thank you very much. Over to you.
No, thanks, Emil Mustafa, for such a, I don't think I'm that much what you introduced, but I'm just simple doctor and try to help other doctors and juniors. Anyways, we start with the main thing, and I'm taking opportunity to just introduce my organization. It's called Irish Pakistani Professional Association. It was founded with a vision to guide and support the new generation, which we spoke, and it's a group of professionals from different specialties. It's not only doctor. We are 85%. We will explain later, but we all believe in collective efforts to promote integration in our society without compromising on our cultural values and beliefs, and to make Ireland a country where people can live with peace, harmony, and respect. So these are the main aims of our organization: to highlight the achievement of Irish Pakistani professionals and their contribution, to provide the professional support and career guidance to the young generation, to help integrate the Pakistani Irish communities and with other communities living in Ireland, and to support community welfare activities. As I mentioned, it has all professionals, but 85% are doctors. And the reason behind that, most of our young generation is, or our children, they are not all doctors. We are trying to build or trying to sow a seed for a tree, which can become a very important for Irish society. And there are a lot of people who are not doctors. We want to be embraced and they will be a part of it, like we are doing even together today with our IT and other specialists. Now I'll just share quickly some Ipa Events and Activities. We founded Ipa or IPPA in September 2018 as a conceptual idea. And then we did a first inauguration ceremony in March 2019. These are pictures from our inauguration 2019, and we are thankful to the APPNE. This is one of the organization UK, and which is very active academically and helping the doctors there. They came all the way and supported us, and they were impressed and learned the Irish dancing here, and everybody enjoyed. And I don't know whether when we will come back to these days again. So then we had a family gathering for IPPA members, and these are a young crowd which we are focusing, if you can see, and they all members had very good time. This is Harun Khan, one of General Secretary's residents, and we enjoyed, and we want to continue such events as well together with academic. We focused on the community work, and there was big need for talking about inheritance law and these kind of topics. With little dry, we took a little effort, and we invited Irish experts, Rory Tyrrell and Jerry McMahon, and also invited few speakers from our side, some clergymen as well from Muslims, and they spoke and they found the ways how we can put the perspective in Irish law and how we can move forward. It was very, very well taken and very appreciated, and good effort it was considered. Then there was some demand that HPAT is one of the important exam for students who want to do medical studies in Ireland. And there's one of our colleagues just put the idea, and then our young doctors who are students in medical college, they came up and they taught people in person, and it was very well taken. It was for all nationalities, not only Pakistanis, for every nationality, including Irish. And you can see the amount of interaction and the benefit they all got. Then the COVID came and we all are affected. And you can see this, we couldn't do anything in the beginning. Then we realized, being a group of professionals, we can pay back to society. So we did some initiative of donation, personal donation, not an open. And then we did some project in which we put some helplines for legal assistance for any accounting problem, or doctors definitely if somebody need. And they were advertised on our social media. We also managed, there was call from Pakistan for PPEs at that time. And this is our colleague and late Professor Dr. Pasha, VC of Multan National University. And we delivered, and he distributed there for us. Unfortunately, he was martyred in the fight of this COVID himself. And we delivered some rations to the poor families in Pakistan there. During that period, we realized, and our IPA Tech, that's our ICT people, they just wanted, with the help of Pakistan Embassy, to do a webinar to help our young generation how they can excel and progress in Ireland, and that they can make more new innovations in the help of with the help of seniors. And this was very well taken, and everybody appreciated this. In August, there was also demand again with the successful HPAT event, and this webinar was organized, and you can see the success rate, how much people gave feedback, positive feedback on this. And again, it was all conducted by the medical students from Royal College, from Trinity College, from UCD, and it's been going on a regular basis. We also focused on the community work then. Cyberbullying was thought as one of the issues we can help in. And with the help of an Irish organization, we organized this cyberbullying for the young people and the families. And it was also a very successful event. There was the big demand for CV writing and interview. And this is one of the areas which most of the foreign doctors are lacking. And with the help of our senior colleagues in Ireland, Professor Gillen, Jane Layden, and Asghar Nawaz from Matter, and Professor David Healy and Asim Ishtiaq, and we have other people down there, and they all, Amr Niazi and Mukhtar and Shabi from UK, we all got together, and it was a very, very good interactive session. And then at that time, the COVID was disturbing everybody, and we felt that we should have more kind of little relaxed event. And this was a literature society event we organized for people from Germany, from UK, from Middle East. They joined, and it was more in Urdu language. It's a local language, and everybody enjoyed that. We got an opportunity to talk for Irish system on a forum in UK, in US, and there were 9 country representatives were there. And this was also very informative for all the graduates from the rest of the world. And recently we did this research and publication as a part of medical training. And Professor Brendan Kelly, who's a very learned professor with a lot of work behind it, and he himself taught, and it was excellent webinar and with very positive feedback. I think we just nearly end of it. These are a few events, will and inheritance, and we are repeating a few other events on artificial intelligence and communication skills. Part 2 might be coming. I think I'll end up my talk here. Thanks very much there.
Without further ado, we'll start the presentation, but just some housekeeping. There will be a questionnaire at the end of the session that is mandatory for CPD points, so please stay till the end to fill that out. It will only take a minute. Our first speaker is Professor Gillen. He's an associate professor of surgery in the Royal College of Surgeons. He's also a faculty member of the Human Factors and Safety Department of the RCSI, and he's a clinical advisor to the National Healthcare Communication Programme in Ireland.
Hey, good morning, everybody. I'm just going to share my screen now. Okay, thank you very much for asking me to speak this morning and for giving me the opportunity. This is my second occasion to collaborate with the IPPA organisation, and I have to say I'm extremely impressed. As you've seen, Khaled has outlined the wonderful work that they do, and I'm very happy to participate this morning again. Just a background, first of all, I'm going to talk to you about a survey. I'm sure that many of you who are attending this morning participated in this survey, and thank you if you did. Following the survey results, I'm then going to speak about communication skills one might use when dealing with angry patients. I'm going to dovetail then with Dr. Sarah Coop from the Medical Protection Society, who's going to speak about breaking bad news. We're going to take both of those talks together and then have a Q&A for a short while afterwards, as both are dealing with very high emotional situations. So a word about the survey. The survey began really as a personal interest of mine into how difficult it was. And actually, having heard Mustafa's wonderful story about the waterworks in Galway, I can see exactly where he was coming from. The survey really was to look at the background, was to explore how communication by doctors was impacted using a language which was not their primary language in an Irish healthcare system. And I think Mustafa's story really illustrates the problem straight away. Then to determine whether self-assessed communication skills were problematic, and if so, how frequently this was occurring. to assess the impact of the duration of time in Ireland on communication skills, whether it was just after you'd arrived or how long the duration of time impacted on your communication skills, to ascertain whether doctors felt confident of support if communication deficits were acknowledged by themselves, and finally to canvass opinion on whether doctors felt that communication skills was impacting or had impacted on their career progression. If we look at just some of the summarized responses from the survey, we had a total of 359 respondents, and thank you to everybody who took the time to fill the survey in for us. As you can see, 82% overwhelmingly male respondents. Countries of origin were grouped into Asia. South Asia obviously would include Pakistan, Africa, Europe excluding Ireland, people who designated themselves as being from the Republic, and some others. You can see that the vast majority were from Asia and Africa, as you'd expect. The survey, I should say, was hosted by Gozi Ofaya, who has a big interest in cultural issues and is a member with myself in Teach, an organisation which promotes the teaching of communication skills as part of the European Association of Communication in Healthcare. It was then circulated by IPPA, and I'd also like to thank the Sudanese Society and the Egyptian Society of Irish Doctors, who also participated. When we looked at the years practicing in Ireland, we can see that 2/3 were over 5 years in practice, over 3 years in practice. So 74 were new arrivals, if you like, and we had 92 people who were 10 years or more practicing in Ireland. In response to the question, have you received formal communication skills training? It's very interesting that over 2/3 had received no formal communication skills training of any sort. And this was seen right across all the groups, as you'll notice. In response to have you encountered communication difficulties with either patients, other doctors, nursing staff, or admin staff, I'll just give you a brief summary rather than show you several tables. In general, most respondents occasionally experienced communication difficulties with nurses, doctors, and admin staff. And difficulties with patients was seen across all groups, with Asian doctors, you'll be very pleased to hear perhaps, reporting less problems in this survey than others. In total, 71% of respondents recognised communication difficulties with patients. This was rather interesting. We asked that if you felt you required extra support with communication issues, would you be confident of receiving that support from either your team members or superiors? And very encouragingly, and I have to say I was delighted to see this, an overwhelming response was in the positive, almost 83% feeling that they would be supported, with only 14% feeling they would not. When we asked about whether communication skills impacted or had impacted on your chances of career progression, I think we have to take this statistic on board quite seriously. 74% felt that, yes, they were impeding their chances of career progression, a highly significant number, while 25% felt it wasn't. We then asked specific questions on what area of communication skills would you like to improve on? And I've listed a number here, but the top 3, if you like, came out as dealing with angry patients, which was the number 1 issue. Dealing with cultural issues came in second, and Dr. Atika is going to speak to us this morning about that. Presentation and interview skills, which Khaled has outlined, was the subject of a previous webinar by IPPA, so I think we're very sensitive to people's requirements. Teamwork issues has been mentioned already this morning, communication with colleagues, and breaking bad news was also prominent. And Sarah is going to speak to us this morning about that. So just a brief summary of the survey findings here. The majority of respondents were male from Asia or Africa with 3 or more years experience. 71% of all respondents reported communication difficulties with patients. The majority had no formal communication skills training. The overwhelming majority felt they would be supported if they sought help with communication issues. And again, the overwhelming majority feel communication skills do impact on their chances of career progression. Now, I would hope that this survey will perhaps stimulate you to put some comments in the chat box and that we will be able to answer some of your comments or queries in the Q&A session. I'm going to speak now about the number one topic, if you like, that came up in your concerns, and that's dealing with angry patients. I have a very short presentation on this, and I would stress that the main way that we improve our communication skills is not by online material, but by actually attending modular training where feedback and role play are essential. And I would like to signpost before I begin to say that you can practice the skills that I'm going to allude to today at Module 3 of the National Healthcare Communication Programme whenever it occurs in your hospital or local area in the near future. And we'd welcome you on board for that. So I'm going to talk a little bit about why do we find it stressful? Well, some of the reasons that we do find it stressful are that the stakes are high. There's a lot at play here, and there are powerful emotions in the room. We may, on occasion, be quite ill prepared for the encounter. We may be stopped in a corridor, doorstepped as we go into work someday with an angry patient, and we may not have had time, and that's very difficult and challenging. We may not have the knowledge. In other words, we might know very much about the case. The handover beforehand may have been incomplete, or we may have been doorstepped and not feel comfortable to impart information. Or, quite simply, we may not know enough about the issues involved. And at that point, it's well worth saying just that, acknowledging that you're not able to answer those concerns, but that you will go away and find somebody more senior or speak to somebody who can come back and deal with it. We may also be stopped, as I said, in a corridor or an area which is certainly not conducive to having a conversation with somebody who is with angry and stressful emotions. We may be unaware of the communication skills needed in such encounters, and as such, especially if we don't have formal training, we will struggle. Equally, we have very little practice and very often no feedback. So after an event, we struggle to know how we've actually handled it. I'd like you to think about, it's a lovely sunny day where I am today, but I'd like you to think about going out for a drive on a day like this. This is a treacherous road ahead with ice and snow, and how we might consider driving on a surface like this. And in one sense, you can see the analogy I'm making. The consultation with an angry patient is so different to somebody who has no angry emotions whatsoever. So when we embark on a day like this to drive, it might surprise you to know that we're not going to use different skills. We're just going to use the same driving skills, but with greater emphasis. That means that we're not going to drive aggressively. We're not going to speed. We're not going to go quickly. We're going to slow down. We're not going to do anything suddenly, like drive quickly up to a bend and jam on the brakes. So that's the same in dealing with angry patients. Everything is going to be more emphatic and at a slower pace. We're going to take our time. We're going to be aware of the circumstances around us and the circumstances that have brought about this problem. We're going to shift gears much more slowly. We're going to drive in less gears. We're going to slow down, take it easy. We're not going to make any huge adjustments with the steering wheel. And it's very similar when dealing with angry patients. I'd like you to bear in mind that anger is usually a manifestation of something else. it may often be worry or anxiety. We may become angry if we feel that we've been blocked from getting something. So ask yourself, what's going on behind this behavior? Why is this person standing over me like this, pointing at me and shouting at me in a manner that's very intimidating? And if you just look at that picture, standing versus sitting, it's very intimidating to have to look up at somebody who's standing above you like that. But by standing up to confront them, that situation is only made worse as it tends to exacerbate the emotions in the room and it strikes a confrontation. So however difficult it is, please remain seated. Ask them politely to take a seat and do what we tend to call mirroring. In other words, if they shout, you speak very gently. After a moment or two, you'll find that they will tend to mirror your body language and your behavior, and they will sit down. It's very difficult to stay angry for very long, especially in the face of somebody who's remaining calm. Now, if this gentleman in the emergency department shouts at you as soon as you pull the curtains back, I've been waiting 6 hours to see you, well, I would caution that you don't say what you might like to say, which could be, well, I've been up all night and I've been here for 12 hours, never mind 6 hours, especially if you're feeling tired and stressed yourself. And consider what we call the Halts acronym, H being for hungry, A for angry, L for late, T for tired, and S for stop. So if you are any of those HALT features, then stop. Don't go in. Get yourself a cup of coffee, a biscuit, whatever it is to get your blood sugar up. Take a moment, a few deep breaths before you go in. It's worth also that if somebody is annoyed, very often you'll be sometimes tipped off or prepared, particularly by nursing staff, to say, so-and-so over there is extremely annoyed and demands to see a doctor right now. Knowing that before you go in will allow you to take a few deep breaths, get your knowledge and information correct about what the person is involved with, and you will have some preparation before you go in. When you're in the room, it's useful to remember this acronym, which we tend to teach on the NHCP, and it's called GIVE. I'm not sure, you may have come across this before, but it's very, very helpful. So if we just look at what each of the letters stand for, the G stands for getting the emotion. Now, there's usually no doubt about it when somebody's angry. It's usually, well, there's no mistake, this is angry. I is then that you identify the emotion by verbalizing. And this is a skill that you need to practice. So you would say something like, I can see you're angry and you're probably worried as well. Now that is identifying the emotion that the patient or their relative is exhibiting, but it's doing something very subtle in addition. Yes, you're acknowledging they're angry, but you're also suggesting that you understand that because they're angry, there's something behind that anger. They're probably blocked from getting something or worried about not getting something. And now you're saying, and you're probably worried as well. That has the ability then to downplay the emotion in the room. And you've now subtly shifted the word anger onto the word worry, which is a more favorable situation for yourself that you can then deal with. The V stands for validate the emotion. So if somebody has been waiting 6 hours, or if something unavoidable has happened and it's a system fault or error and not yours, then rather than say, well, that's not my fault, that's the system, that isn't going to help somebody. It's perfectly normal for you to think that way, but it's not going to help. So you're better off saying, look, it's normal for you to be upset with what has happened to you. And I apologize for that. By apologizing, you're not saying that it's your fault. You're simply saying that you're sorry that they're feeling this way, even though it is understandable that they're feeling that way. And finally, the E is for explore the emotion. So now you've said to them, you're angry. I can see you're angry and you're probably worried. What is your biggest worry here? And that will help them then to articulate what the problem really is and will allow you to deal with it. I'm going to leave you now with just some angry patient helpful phrases that you might leave. So, for example, for somebody waiting a long time before you get to see them, particularly in the emergency department, I'm sorry you've had to wait so long, but this is your time with me now. If you look at the way that sentence is constructed, it's acknowledging that they've had a long time to wait and that it's been tough for them. But you're also saying to them, this is your time with me now, with nobody else, just me. I am totally focused on you for the next however long it takes. There's also a subtle hint in there that they have a certain finite time with you. And if they insist on shouting and giving out, then they are in fact using up their own time. So it's a nice way to control and de-escalate a situation. Equally, and these are not exclusive, they're just suggestions, I'm more than willing to hear your side of things. So take your time so I can get the full picture of what's been happening and what I can do to help. It's very difficult to be very angry back to somebody who's so conciliatory and using language like that. I'm sorry this has happened to you. Let me recap what you've just told me, which demonstrates that you've been actively listening. You can then repeat back to them or paraphrase it in your own words as to what they've been told. So you've been waiting for a long time. You've come in with this. Let me see what I can do about that. And now let me see where we go from here. Finally, a word about yourselves. Don't underestimate the impact such encounters have on yourself. Take time to reflect on what's happened as you make your notes directly after the consultation. Sharing the episode with a trusted colleague may be helpful, but there's a slight warning note here. Whenever we've been involved in really fractious encounters like that, we tend to seek out somebody who's going to be a shoulder, if you like, that we can lean on. And we tend to say, oh, they said this and then they said that and then they shouted at me. And you'll find that somebody will say, oh, that's awful. Oh, you poor thing. Oh, that's terrible. And psychologically, that makes you feel better. But we all tend to over-exaggerate our own role in all of these encounters. And we don't really give an objective assessment of what just happened. So while it's useful to get a little bit of psychological support to keep you going, remember that the only way your performance is going to improve is that when you've calmed down and when you've had time to reflect, that you go and speak to a mentor about the confrontation and say, when they said this, I said that. But it only made it worse. What are your thoughts on that? What might I have done in a different way, or how could I improve? As I said, these are just snapshots of dealing with angry patients. It's very high emotional content. You do need to do some role play and get some accurate feedback. And I would encourage you to attend the National Healthcare Communication modules when they're next in your hospital. I'm going to end there and I'm going to ask Sarah to deal with breaking bad news now. Thank you.
Thank you very much, Peter. I think that's really helpful in terms of thinking particularly about the analogy of driving on ice. Slow down when you're dealing with an angry patient, take your time and steer carefully so that you don't end up crashing. I think that's a really helpful analogy to keep in mind. So thank you very much. I'm really delighted to be joining you all at today's event. My name is Dr. Sarah Coop. I've been a GP for about 20 years, and I'm now working as a senior medical educator at Medical Protection. And this next section that I'm going to take you through is a taster of resources that the Risk Prevention Education Department, which I'm part of at Medical Protection, we offer to our doctors who are members, really to support effective communication and to reduce that risk when interacting with patients and colleagues. So I'd like to now give you an overview of communication skills that can be extremely valuable when you need to break bad news. This is a specific situation that Peter identified from the survey as a challenging area that some of you might have found. And I know that many doctors across all specialties and levels of seniority can find it really difficult to do well. So firstly, let's consider, what is bad news? So just for a moment, think about what you might say. Robert Buckman, he was a Canadian oncologist back in 1984. He defined bad news as any information which drastically and negatively affects an individual's view of his or her future. So this definition encompasses a broader range of scenarios than what we might immediately think of when considering breaking bad news. I think often our first thoughts of situations involving bad news might be those where we need to inform a patient that they have terminal cancer, or where we need to speak to a relative to say that sadly their patient, their next of kin has died. However, breaking bad news can also include letting a patient know that their procedure or their follow-up investigation is likely to be delayed, perhaps due to backlogs associated with the current COVID pandemic. Or it could also include giving them results of a test that's life-changing. So, for example, that they're now going to require renal dialysis going forwards. So I'm sure that all of you will be able to think of breaking bad news scenarios that you deal with in your own clinical specialty, where you're giving news that potentially has that serious negative impact for the patient. And what happens if these conversations are not handled well? So if you bring to mind situations that you've either observed or that you've experienced yourself, I think you'll agree with the evidence that shows if it is handled poorly, it can really result in additional distress for the patient and sometimes their family as well. And it may lead to a breakdown in that doctor-patient relationship and even complaints being made. And on top of this, breaking bad news can lead to significant stress for the doctor themselves. One study found that the negative effects on clinicians can last for several hours, even days. So it is a really important area that we need to look at so that we can improve our communication and reduce that excess stress and distress as far as possible. And I think this is particularly pertinent in the difficult conversations that many of you are having to have relating to the impact of the pandemic. So I've got a poll question now to ask you. I'm just going to launch this poll. I'm interested to find out whether you've had any previous training in this area. So please would you click on the appropriate response to indicate whether you've had either formal training at an undergraduate level, a postgraduate level, or no formal training. I'll just give you a few more seconds to answer that and then submit, and then we'll have a look at the results. So I can see people are answering, which is great. So any formal training as an undergraduate, as a postgraduate, or no formal training. 60% of you have voted, so I'll just give another few seconds to see. Okay, so I'm going to end that poll and we'll have a look at the results. So the results show 53% of you have had no formal training, 25% formal teaching as a postgraduate, and 22% formal teaching as an undergraduate. So thank you very much for answering that. And that's interesting to see. So if the poll slide hasn't disappeared, just click on that to close it off the screen. And research showed that breaking bad news was even more stressful for those clinicians who felt they hadn't had sufficient training and practice in this. And as I said, it's not surprising that some doctors have identified that they find it particularly hard when their primary language is different to the patient's. So I'd like now to introduce you to a communication framework that I hope you'll find helpful. It's called the SPIKES framework. It was first described by Robert Buckman, the oncologist that I quoted a few slides ago. This framework is not a script, but it does really provide a useful strategy for these difficult conversations. I think you can use it as a cognitive safety net to support that effective communication with your patient. So as you can see on the slide, SPIKES stands for setting, perception, invitation, knowledge, empathy, and strategy. And I'll give you a few points as we go through on each of those. Some of you might have heard of the SPIKES framework if you had that teaching as an undergraduate or postgraduate, but for others of you, it might be new. And at the end of this talk, I'm going to ask for a link to be posted in the chat box by our moderators to an article written in September 2020 on the use of the SPIKES protocol amongst Sudanese doctors. And that showed that with training and ongoing skills practice, it really did significantly improve their communication in this area. So you might want to have a look at that article. So step one. When using the SPIKES model, the first step is to consider the setting of your consultation and just spend a few moments to ensure that you are adequately prepared. The purpose of this is really to gain that trust and also create confidence with the patient from the start. So it's worth asking yourself questions such as these. Do you have all the facts and the detail that you need about the patient? Are you up to speed with any recent events? Have you reviewed relevant test results? And is there somewhere private, comfortable and quiet that you can use? So really never having these conversations in a corridor, and ideally not behind a curtain. I know that's sometimes unavoidable, but a curtain doesn't offer any real privacy. Do you have tissues available? And are there enough chairs set out? And are they arranged in a way so that there's no physical barrier between you and the patient? So no desk between you. We need to avoid interruptions wherever possible. So have we notified staff not to disturb us? And have you switched off your phone? And also just thinking, does anyone else need to be there to support the patient during and afterwards? This might be a relative or an appropriate health professional, such as a clinic nurse, if available. The second stage is about establishing the patient's understanding of their situation so far and their perception of how things are for them at this point in time. So it's their current reality. And we need to do this before we then give them the bad news. So remember, ask before tell. I'd say start with open questions to gather that information from the patient and build connection. Questions that begin with who, what, where, and when. And ask them about any recent events or changes in their situation, because something might have happened that you might not be aware of, and that could alter then the decision-making going forwards. And then move on to other questions to explore the patient's perspective and expectations, such as these questions that I've put on the bottom half of the slide. And throughout all of this, it's really important to just check in with yourself. Are you actively listening? Are you demonstrating good quality attention through things like appropriate eye contact, not interrupting, using summaries to recap what they've told you? And that really helps to show that you're seeking to understand them. The next step is then to obtain an invitation or permission for you to tell them the medical information that you have. We can't assume that everyone wants to know everything. Most people do want to know the full details of their situation, like the facts, the implications, and the plans. But research does show that about 1 in 20 patients only want to have a brief outline. So examples of questions you might ask patients before giving them the bad news could be, how would you like me to tell you about the test results? Would you like me to give you a lot of detail or more an overview of the results? And if patients don't want to know the full details at the time, of course, we must make sure we obtain consent before we disclose it to a third party. So once the patient has invited you to proceed, then the next step is imparting that medical knowledge to the patient at the level that they've agreed to. So this is where you give them the information and the facts that relate to the bad news. And I think most of us would have gone in with this information bit quite quickly and often not established the patient's perception and invitation first. So we want to check that we've signposted where the conversation is going. So this could be by providing a warning shot. And that warning shot enables the patient to psychologically brace themselves before receiving the bad news. So a warning shot might sound something like, unfortunately, I've got some bad news to tell you. Or, I'm sorry to have to let you know that the results are quite concerning. And then provide the bad news in small chunks and pause regularly to check that the patient has understood and digested this before providing any more. So listen out for any medical jargon that you use. Like Mustafa said at the beginning about central lines, patients don't often know what that is. So try and speak the patient's language. So if you hear yourself using any medical jargon, rephrase it and say it again in another way that speaks their language. This knowledge and giving information part, we mustn't rush it. We need to allow time for questions as we go along. This will really avoid misunderstandings being made and also help us tailor our explanations accordingly. And just to ask ourselves throughout, am I communicating with honesty, openness, and conveying care to the patient? And although you may have frequent similar conversations with many other patients, for this person in front of you, it's really highly significant. So it's important to demonstrate that their particular situation is of value right now and that you are alongside them in order to be supportive. A bit like what Peter was saying, this is your time with me now. We want to make sure that we're conveying that as well. Fifth step, Theodore Roosevelt said, people don't care how much you know until they know how much you care. And that takes us into this aspect, which is empathy. And for many clinicians, this is one of the most challenging parts of breaking bad news. You don't know how the patient is going to react until they do. So it's both an unknown and it's also out of your control. And reactions to bad news can vary widely from anger through to silent shutdown. And it can be very uncomfortable for the doctor. You might somehow feel responsible for the patient's emotional expression. So what's our role as clinicians at this point? I think it's simply to be alongside the patient in their distress, to offer support through empathy, to show respect and kindness. So how do we do that? I think very similarly to what we talked about earlier, what Peter talked about in the give analogy. Firstly, notice the emotion that's being expressed. Is it sadness, shock, grief, anger? And secondly, reflect back to the patient what you sense they're feeling and demonstrate understanding, validate their feelings with a connecting statement between the facts and the feelings. So you might say something like, I can really see how upset you feel, and I know this isn't what you wanted to hear. I wish the news were better. When patients are expressing emotion, it's really difficult to proceed any further until that emotion has diminished. So we do need to stay with it by continuing to empathise until they become calmer and are able to carry on. So the final step then is to agree a strategy for going forwards. Some patients aren't emotionally able to engage with this part of the discussion straight after hearing bad news, so they might therefore need to wait for a further time. So I'd suggest check with them if they wish to discuss the next steps now or leave it for later. And that might obviously depend on the clinical context, the urgency, and other relevant factors. Key skills for this step include recapping, summarising back over the conversation so far, explaining the reasoning, and then negotiating decision-making to make it right for the patient. Of course, current limitations of resources can mean that different options aren't always available or practically possible. So we need to be honest with the patient about what's realistic. We don't want to take away hope from them where possible. Clarifying the action plan also helps to reduce misunderstandings, because otherwise that could lead to dissatisfaction or adverse outcomes. And then, of course, it's important to provide that ongoing support by arranging follow-up with the most appropriate person, and if relevant, backing it up with verbal information and allowing time at the end for any further questions. So just going back to our summary slide for spikes, showing those 6 steps again: setting, perception, invitation, knowledge, empathy, and strategy. And I think through all of this, it's really important to keep in mind what the patient finds is the most important thing. What they will remember from the bad news is probably your manner, even more perhaps than the detail of the message that you give. So I've summarised this on my final slide really as 3 A's. Ensure that you're demonstrating a positive attitude of respect and honesty, giving the patient good quality attention, and showing acceptance of their feelings through kindness and understanding. We all agree that breaking bad news is certainly challenging. I just hope that you can see how you might helpfully use these communication skills yourself with patients. So I've given you a simple overview of the Spikes framework today. In the chat box, we're going to post the link to that article that I mentioned earlier that you might want to take a look at. And I'd also invite you to have a look at the medical protection website. We've got some resources on there that are available to all clinicians relating to COVID-19. And if you are an MPS member, you can log on to your e-learning account Prism to get some additional education activities. Rachel Lynch, our business lead for Ireland, is going to join us at the end of the session, and she's going to talk to you briefly about what medical protection can do to support you in your clinical work here in Ireland. So I'm going to stop sharing now, and Peter and myself are happy to take questions that might have come up from our sessions so far. Thank you.
Thank you very much for the excellent talks. There's a few questions in the chat group. One of the first is for Prof. Gillen. If an angry patient may be Irish, Asian, African, or Eastern European, all have different cultural attitudes, may also not understand the health system in Ireland, or frustrated by delays or investigations, or not be able to see a specialist, what would you advise in that regard?
Yeah, okay, thanks for that question. Nice, difficult one to start off with. I can see where that's coming from. Again, it's interesting because we're talking really about cross-cultural issues, and the question's been turned back on me. While this was about communication difficulties for doctors whose primary language isn't English, then what the questioner has said, what about patients whose primary language may not be English? So that does complicate the issue. There's much more literature about difficulties demonstrated by patients whose primary language isn't English than there are about doctors, which was the reason to start the survey. So I would just sort of like to say that it does highlight intercultural differences have every opportunity to lead to misconceptions. So I think at that point, I would do what I was saying at the beginning. That is another driving on ice situation. Really slow down, be very clear, take as much time as possible to understand what the patient's perception of the problem is before you try and address it. So it's going to be even more difficult and more challenging. With regard to not being able to understand the system, very often as doctors, we end up apologizing for the system, which we did not design and have no great input into. But that doesn't mean that we don't have to apologize by simply saying, I can see you're having a tough time accessing whatever they need, because that again will demonstrate empathy. When you have nothing in the box left, then you have empathy, and don't be afraid to show it.
Thank you very much, Dr. Professor. There's a few more questions. One is regarding if you're talking to a patient and they're getting angry, if you're discussing something like their weight or to stop a smoking habit, and they're getting very, very annoyed by this, how would you tackle that?
Okay, again, it's a very common one. And I'm sure that there are other experts like Sarah and Rita will have come across this in general practice a lot more than perhaps I have on occasion. I think the thing to do is to be empathetic. Somebody is not liking the message that's good for them. So what's behind that? What are they afraid of? Why are they not engaging in the news that if they do try and lose weight, their general health will be better? So try and get the stresses and strains that are behind the attitude first. And then it's often worth giving people some literature maybe to read, not right in front of you at the time. Leaflets are all very well, but they're really best utilized when the patient goes home and has a chance to go over them. And if things are getting too heated, then all you can do in a situation like that is give the advice. And I'd be interested to hear what Sarah and Rita say. Give the advice that you think is the right thing to do and ask them to perhaps reflect on it when they go home. I don't know, Sarah, if you wanted to add.
Yeah, if I add something there, I think that those points are all really helpful, Peter. I think these issues around perhaps giving advice around weight or other lifestyle changes, patients can get defensive, and then that can escalate into anger if they feel that they're being told what to do or feel that they're being criticised. So I think one skill that I learned was under the umbrella of a technique called motivational interviewing. And I think what that often helps to encourage us to do as clinicians is to try and get the patient to come up with the ideas about change themselves before you suggest it. So that would include, some of the questions we had on the slide. What ideas, what thoughts have you had about this situation? And try and get them to say what they might do instead. So it's not you telling them. So it goes back to ask before tell. I think that can be helpful. And I think if someone does become angry, using your thoughts there, Peter, what's behind that? I think I'd probably sort of say, I can see that you're feeling quite a little bit defensive about this, or you're feeling quite sensitive, and I apologise, that wasn't the intention. What I want to do, and take them back to the goal, is to work with you so that you can improve your lifestyle so that your health is better. So try and bring them back to a positive outcome. So I think ask before tell, encourage the patient to come up with their own ideas and suggestions, acknowledge the emotion again, and then try and reframe that in terms of a positive intention.
Thank you very much. One of the questions for Dr. Sarah is if we have to use an interpreter to communicate to the patient, does that breach confidentiality, or is that something that is allowed?
That's a good question. Thank you. That wouldn't breach confidentiality, assuming that the patient's given consent for the interpreter to be present. So that's the issue there, that as long as the interpreter has got consent to be there by the patient, then that's not going to breach confidentiality. So, and it helps, doesn't it, to avoid misunderstandings, helps to make sure that the messages are communicated clearly. So hopefully that answers that question.
Another question was regarding if you're breaking bad news and you have to share the details to the patient, but they're adamant not to share with their wife or relative. Would that be something that is okay, or would they have a support network?
So the question is asking if you've got to share with the patient, but they don't want their wife or other relatives to be aware. Yeah, so it's the patient's decision, as long as they have capacity to decide who knows the news. So we would be able to reassure them as doctors that it's their choice. And obviously we shouldn't break confidentiality unless they're given permission around that. I think it's often helpful to, if they're choosing not to share the news with relatives, it can create some difficulties, can't it, in terms of relatives sort of demanding to know the news. But obviously, we can't break that unless the patient has given us permission. And I think just checking with the patient that they have other support. Do they want to then speak to a clinic, another clinic specialist, a nurse? Do they want another professional to help them so that they're not carrying all of that news by themselves? I think is really important. I don't know, Peter, if you want to add anything.
Yeah, just to explore why, for example, they don't want, very often when that's explored, they feel that maybe their wife wouldn't be able to cope with the news or something, and that's often the exact opposite. And by broaching those kind of concerns, you might explore the area then as to what their perception of going forward is. They might feel, oh, I don't want her to know this because I won't be alive in 6 months and I won't be able to do this, that, and the other. And so that a whole host of misconceptions can come out. And also, very often people's relatives are much more supportive sometimes than an individual like that might actually feel. So it can be worth asking why they don't want to.
I think that's the key, isn't it? Finding out what's behind their response. Yeah. Can I just ask what makes you say that? I think is often a good question. And what's stopping you from telling your family? Not because I wanted to pressurize you to do that, but I'm just interested to know so that I can be supportive. I think that's helpful. So we don't make assumptions as to why they're not telling, or there might be another reason that we're not aware of. Yeah, thank you.
That's a very good scenario. And think Dr. Doyle, and you have any experience as a GP, like how you deal this problem?
Myself, yeah, as a GP.
No, sorry.
Dr. Doyle, yeah.
Yeah, yes, I would. I mean, I think the reverse often happens, where the relative might approach you and say, don't tell the patient, particularly with older patients. And my answer to that is that I will never tell the patient a lie. If the patient asks me, then I'm not going to tell them the bald truth, but I'm not going to tell them any lies, particularly with older patients. They sometimes don't want to know, but more often than not, it's their relatives that don't want them to know. And of course, in my head, you must respect the patient's wishes first rather than the relative's wishes. So that's just another area that it happens in.
Thanks very much.
Just to add one more comment maybe on Peter and dealing with angry patients. One of the things that I keep in my head always when I'm listening or receiving the anger is that defense is the first act of war. So the last thing I'll do is defend myself at that moment. Maybe in a few weeks' time or whatever, but at that moment, I think you aggravate their anger by saying, well, I didn't do anything wrong or whatever it was. Okay, so it's just something that I keep in my brain when that situation arises. Thanks.
We might just take one more question if we have time. There's one from ED. This says, does a patient not have responsibility to respect the healthcare professional who are trying to help them to their best of ability? There has to be balance. I believe anger sometimes need to be dealt with firmness. Notice in ED if there's zero tolerance. This is a case of a combative or abusive patient.
Yeah, and thank you, Malik, for putting that up. There are notices about zero tolerance, and I don't think any of us in healthcare would ever tolerate somebody being abusive to the staff. One of the difficulties we have in drawing the line there is that it's usually because with high emotional situations like that, there's a reason behind it. I don't mean to repeat myself, but that is the problem, that people are reacting to something and behaving in that manner. And if you can mirror a behavior which will de-escalate the situation, you can get quite quickly to that. And then that will help you to deal with the problem. But as Rita said, if you become defensive, and Sarah and I agree that if you stand up and confront somebody's anger, it's not going to go well. It's only going to escalate. And that will actually increase the risk of further confrontation and even perhaps physical violence on occasion. So none of us want to see that. And while I agree that we need to take care of our staff and ourselves, and we need to put reminders in place for people to behave in a reasonable fashion, we are dealing with healthcare here. And when people are concerned and worried, they do become extremely anxious and can on occasions come across as verbally quite abusive. But we're trying to talk about techniques to de-escalate that. So Malik, I fully respect what you're saying and about the dignity at work. but I would counsel that de-escalation is a better way to deal with it in the first instance.
Exactly. Coming from an emergency department, particularly working in Dublin 8 and James's, where people are really, really vulnerable who come in, and there's always a reason why someone is angry. There's always a reason. Offer them a cup of tea. Ask them to go out and have a smoke, as much as we don't like smoking. Trust me, it de-escalates things 99.9% of the times. Offer them a cup of tea, offer them a sandwich, ask them if they want to go and have a smoke, and give them 5 minutes. And once they're back, once they have had their cup of tea, they've gone for their smoke, trust me, they'll be much more compliant with your advice. And this is someone who deals with really vulnerable, really angry patients day in, day out.
Thanks very much.
Thank you very much for all those answers. We might move on now for time's sake. The next presenter is Dr. Atika Rafiq. She is a consultant old age psychiatrist in the mental health service in County Louth.
I'm just going to share my screen. My name is Atika Rafiq. And thank you so much for inviting me to speak today. I'm absolutely delighted to have this opportunity today to speak to you all. And like most of you, I'm also an immigrant. I came to Ireland in the late 90s. And one of the first observations that I made, I'm going to share with you, was something like this. So this isn't a judgment. This is just my personal observation. When I came to Ireland, I started noticing certain differences. I noted a lot of calm about the place. I felt that people didn't seem to be in a mad rush. They didn't mind waiting, generally. And, it isn't, beyond a certificate of citizenship. It is correct that you cannot define at all. There's no definition of what makes a Pakistani and what makes, an Irish or, what makes a Nigerian or a South African. But there are a whole range of reasons because of which people differ. There are differences in ways that people interact and communicate in different cultures and societies. And that is going to be the point of my presentation today, to come at the whole communication skills from the angle of those differences that we, the immigrants, have to navigate when we come to Ireland to work. So obviously, one of the first things is the language itself. Mustafa earlier on kind of shed some light on it from a different angle. I believe for a lot of doctors, is it the English language itself? I think that when your language of instruction has been English for 5 or 6 years, you know the language. Is it then the proficiency of spoken English? To some extent, absolutely, and it can hold us back. My understanding is that for a lot of immigrants, it's the challenge of how best to say something. It is, for example, I'll just give you a phrase, it may be quite all right in certain cultural contexts to say, for example, it's all in your mind. There's really nothing wrong here. How would that go down here? Is that something you would say to the patients here? I think you know the answer. In some cultures, in my own home country, Pakistan, when you want to give a patient hope, you may say something like, I'm doing this for you, but, God will look after it. Have a bit of faith. How's that going to go down here? So it is to be aware of the differences and what's okay and what's really not okay, and, learning the best way of saying something. There is then another aspect of speech, which is the way we speak. It's the emphasis. It's in our tone of voice. In some cultures, and again, I would keep going back to, my grounding in Pakistan. what may be considered as passionate speak in one culture may actually go down as a bit of aggression in another. Not all the time, but it can be. So it is just about that sort of awareness. I have had, a couple of colleagues over the years, junior doctors, and heard kind of patients, complaining about the manner, whereas I would have known them to be actually, very good doctors. It's just, I think, the way sometimes we emphasize things. And then there's this whole other language, which is called the body language. And we know well that, and it's been shown by research, that 60 to 70% of your communication, of the interaction, is actually nonverbal. 60 to 70%. And it's this whole other language. It starts with your posture, your eye contact, your facial expression, smile or lack thereof. And then, your personal space, how much distance between two people. There are certain things that have huge cultural notions or sometimes, religious notions attached to them. For example, a handshake sometimes is simply, a gesture of politeness in this country, in Ireland, and yet, on the other hand, there are cultures and countries that use this hand language. Italians are particularly famous for it, different kind of gestures. Where I come from, people use hands a lot, and hands can take different positions. I think I'm doing that a lot today as well. I didn't intend to. It just automatically happens. And there are certain hand gestures, and really, there's no emotional significance attached to any of this. I have seen people kind of casually kind of beckoning people with your finger, or like pointing finger to explain something. Some of these things have a huge emotional significance, or maybe a meaning attached that I have learned, time and time again through my years in Ireland. That it may actually be considered rude. So it is just coming down to understanding this, so how do you then, and why do you then need to work on communication skills from the cultural perspective? I would say that if you're among the 72% doctors that Prof. Gillen was talking about earlier, who feel that they're being held back, in their profession, you have to really start working on it as if you were working on a project. And you have to do this, without delay. You have to look at it as skills deficit. And I would advise that you start working on that right away. And you set yourself some goals, some achievable, measurable goals. For example, some of you might think that a measurable goal may be that in your current 6 months placement, by the end of it, you're going to do maybe 2 presentations in front of your academic meeting or your grand round. For others, it may be something different, but measurable, achievable goals, and then work towards them. And how do you do that? How do we learn any skill? We observe, we learn, and we practice. And it's practice that improves us. But the starting point needs to be a little bit of self-appraisal. It is absolutely essential to identify what kind of communication difficulties an individual person has. Ask yourself the question, what is it, about my specific communication issue? Is it that the patients don't seem to understand me and they have to keep asking me again and again, to explain myself? Or I have an issue with maybe just focused, kind of getting the message from them, and I'm asking people to kind of repeat themselves again and again. Or unintentionally, I am, I seem to be offending people, whereas I have no intention of doing it, So it's important to identify first and foremost, make peace with it. And, without that, you cannot proceed to make any changes. Now, in no particular order, just a few tips that I have to offer, just learned, through my experience over the years. is to make keen observations. This is how we learn all of the skills. And it does not get better than when you're already in a country, you're in a medical practice in an English-speaking country. You will have around you in your workplace people who are excellent communicators, and then you will have around you some who just cannot seem to get to the point when they're trying to communicate something. They're just not so good at it. So just observe how they are different. What is it about that style of communication that is so helpful, when you're on the receiving end of it? And it is about then refining your own style and perhaps adopting some of those tips, some of those styles, as you grow into your own communication. And about then, this whole, I suppose, challenge of, how best to say something, So again, you can practice it in your own time. I think it's about actually allocate some time to doing this. It's about learning how just take one phrase and find a few different ways of saying the same thing. Okay. And again, back to the old phrase. There's nothing wrong with you. It's all in your mind. How best might you phrase to get the best outcome for the patient without offending them? Can I give you another one? Yeah. Oh, I don't agree with your decision. I think, you need to do something different. Okay. So think about maybe 2 or 3 different ways of saying the same thing. And you can then just make observations and see how different people tend to approach this. There is always many ways. There are many ways of saying the same thing. It's just learning to refine our style of communication till we know it does not come down to a scholarly vocabulary. It's just a simple message, but how best to deliver that message. And my last tip is a thing that's been said in different ways already. It's active listening. So I would urge you to look it up in your own time. If there was one thing you would take from my talk today, is to develop active listening. When a patient is talking to you, when a colleague is talking to you, when any other person is talking to you, but very importantly in doctor-patient relationship or in an interaction, you have to be present. What really happens is that we ask a question, and because of time pressure, you're on call or you're in an exam situation, whatever else is going on, the patient starts talking and you're already thinking about the next question you're going to ask. It's not helpful. It shows in your expression, your body language changes, you're vacant, you're not really there, and the patient is very quick to pick on it. It will get the best outcome from even a short interaction if you started with an open-ended question, allow the patient to lead, because then they will present first what matters most to them. And during all of that, listen, be present, and then probe. That would be my advice. When we listen, it's a skill that needs to be practiced, and you can actually practice it all the time. You can practice it at home. For example, your housemate or your spouse or your child approaches you. Try to just put your laptop away. Just turn the phone upside down, put it away, be present in that communication. You can practice it all the time. You can focus on maybe when you're listening to, say, RT News, you take, I suppose at the end of it, just reflect on what was the news today. How much attention did you pay? What did you actually get from it? So you can individually practice your listening skills, but in a doctor-patient interaction, I would urge you to really practice, being present, paying full attention. Use nods, use your gaze, your eye contact to assure the patient that you're present, you're listening. don't, it's that habit that I have observed time and time again, is of sort of saying, okay, every little silence that the patient presents, the doctor is inclined to say, okay, sometimes 2 or 3 times, it's like, rushing the patient along, not good habits, the patient will give you all of the problems in the shortest amount of time if they have that space and if they have that comfort that they have a listening ear. And if you've been actively listening to me so far, I thank you for your attention, and I would welcome any questions.
Thank you very much, Dr. Atika, for your wonderful presentation and valued advice.
In regards to Dr. Atika's talk, it was an interesting one based on ICU patients who are on ventilator and minimal sedation. How can we help improve our body language in that regard to communicate to those patients?
It is a very interesting question. And I, being a psychiatrist, I'm not the expert on how to actually advise you on this. Are you talking about, how with you is the patient at the time, how alert, what is the subject of this communication that we're discussing here? Are you going to talk to them about their treatment? I think it just comes down to that. And I will invite any commentary from maybe people who do have more experience of these situations, actually.
I think we have 2 people here. That's Professor Gillen and Dr. Mukhtar. They spend most of time in critical ill patient in ICU. They can answer. And we rephrase the question again, Mustafa, for audience sake, please.
The question is how to communicate with patients who are ventilated in the intensive care unit or are on minimal sedation. How to use your body gestures, your language, what sort of tone do you use? It's a very difficult question, all right. I'll leave it to the experts.
Okay. Prof. Gillen, you want to say anything? I can. I'm not ICU expert, but I can.
You go ahead, Mohammed.
Okay. The thing is that it's a basic same principle. And while we anesthetizing the patient, we explain everything. And even the induction dose is given, still we are talking that what we are going to do it. You don't remember because every patient is different. And every patient needed different doses. And same thing is under the effect of sedation. You don't know they're deeply sedated or they're minimally sedated. You want to treat them as absolutely with the respect as you're treating a fully awake and alert person. So you explain every event. And the best thing is to learn from the ICU nursing staff. And they communicate, they're expert in that one. If somebody doesn't have the experience and wants to know, then learn from that. Every posture changes, feeding, changing the line, changing the dressing, they try to explain as they are doing the first time. Maybe they're doing that event maybe 100 times, if the patient is long-term staying in the ICU. But they don't ignore that patient is sedated and what kind of sedation is. Like I remember during my training about 20 years ago, working in the court, and we brought a patient back who was in ICU for a long time. And the patient, is a question answer session. That was the best kind of session in my life. The patient was saying which doctor, because he stayed for a long time. He remembered the voice of the people. Later on, he acknowledged the names. He was saying what person was talking, what time, and what they were saying. It was, believe me, astonishing that what we thought that he's not aware, he was aware of everything. So that's briefly I can say.
As a crucial part of learning communication skills. And so while reading about communication skills or attending a webinar which talks about them is beneficial, by far the most productive way of changing people's behavior, as Rita said, is to watch a video or to role play and then to have constructive feedback. And that's when it has to be well modulated, because if the feedback is not given by expert facilitators, it can be quite hurtful or harmful on occasion. Most people tend to give feedback by saying, you forgot to do this, you didn't say that, you made a mess of this, because we tend to pick out things that people did wrong, whereas we should begin feedback with, how did that feel for you to do that? How did you feel when you said this? What was going through your head when you said, do this, this, and this? I would really counsel on that.
Our next speaker needs no introduction. Dr. Rita Doyle is the president of Irish Medical Council. She is also a general practitioner by trade, and she told us earlier that she was vaccinating all day yesterday, so she's a bit tired, I suppose. But she's still here. She has held the Medical Council together through this pandemic. Thank you very much, Dr. Doyle, for that. Over to you for your wonderful talk again.
Good afternoon now, and thank you for asking me to talk to you today. It's a real privilege and an honor to be able to talk to you. And I suppose communication from the Medical Council's perspective is very didactic as opposed to that active listening that Atika was talking about. But I hope that your experience of the Council will be that you do feel that you are listened to and are treated fairly. Just a little bit about the Council. It's the regulatory body for doctors, and it has a statutory role in protecting the public by promoting the highest professional standards amongst doctors practicing in the Republic of Ireland. And that is how we support doctors, is by promoting best standards. We maintain the register. We're the custodians of the register and decide who is eligible to be on the register and who is not eligible. The third point is that we set the standards for medical education and training in Ireland. And I think this is probably the most important function of the Council, is actually that we set the standards and then monitor their maintenance. We oversee lifelong learning and skills development throughout doctors' professional careers, from the time that they start as medical students until they're at their postgrad and indeed in their retirement stage if they wish to stay upon the register. We are the place where the public may make a complaint against a doctor. We're better known for that than for the other things we do. But bear in mind, it's only about 20% of the work that we do. And we are governed by the Medical Practitioners Act 2007. Like it or lump it, it's not a great act. It's very proscriptive, but we have to work within that act. We produce a lot of research, and one of the main ones is the Medical Workforce Intelligence Report. And the most recent one, I think these statistics are very relevant. This is important. There are 1,380 doctors reporting being clinically active and working in Ireland who received a primary medical qualification in Pakistan. So you guys represent 7.7%, almost 8% of the register. And I think that that will give you, if you know that, that will give you some clout to speak for yourselves. And 1,809 doctors, or 8% of the register, have a passport from Pakistan. So I think those are very interesting figures. You're a bigger body, I think, than you actually realize. This is, you probably all know about our ethical guide, the guide that shows you the ethical behavior that is expected of doctors who practice medicine in Ireland. And this is a quote from the ethical guide. Good communication is central to the doctor-patient relationship and essential to the effective functioning of healthcare teams. I think we remember that we learn to talk as a child, but we learn to communicate as we go through life, and talking is not communicating. Atika has talked about listening. Listening, to me, listening is the most important part of communication. So it's not actually talking. We think that once we learn how to communicate, that's it. I think we can always improve our communication skills. And I would still take communication courses because patients tell me regularly that my face says it all. So I have to learn how to get a poker face sometimes because apparently my physical aspect shows them before I open my mouth exactly what I'm saying. You have to be aware of these things. Okay, doctors still remain the most trusted profession in Ireland. I think actually that the pharmacists pipped us. This one doesn't show the pharmacists. I think they're about 94%. So it's interesting that people trust pharmacists more than doctors, but we're still the most trusted profession. And That's the 2020 study, so it's up to date. But a patient recently said to me, yes, but a slap in the back, a pat on the back is not far from a slap on the bottom. So we have to maintain that trust, and we have to work at maintaining that trust. Communication complaints as seen in reports. Okay, so complaints received by the council about doctors we have about 44 different categories. However, 19% of all complaints fell into the category of communications in 2017 and 2018. It was a little bit less in 2019, 16.7%, and we don't have the stats for 2020, but 2020, as we all know, to our cost, was a very unusual year, and how we can judge about that, I'm not sure, but certainly a large proportion of complaints are about communications. And I suppose issues of poor communications are not acceptable. It's not acceptable to the patient, and it's not acceptable to the medical council. We're dedicated to improving the patient experiences by supporting doctors and supporting communication courses. It is clear that we need to put a particular emphasis on communications at this current time. And I listened to you on how to communication with an unconscious patient in the ICU is an extreme of a communication skills, but the day-to-day communications can always improve. We're developing a number of new initiatives to support doctors by providing additional guidance to further enhance good communication with patients and their families. What is a communications complaint? A misunderstanding, not explaining a diagnosis or treatment plan in an understandable or clear manner, a disagreement, personality clash. You can't get on with everybody. And I don't know about you guys, but I certainly know when somebody doesn't like me, and you have to bend over backwards in that situation to make sure that your communication is adequate. I know that prior to COVID, we would get what you might call silly complaints, like when a doctor turned around to the patient and said, "Not you again." The doctor was at the end of his tether, tired at the end of the day, and Mrs. B is back in for the 6th time in 6 weeks. And so that actually engendered a complaint. And as you know, currently any complaint has to be investigated. That's changing with the new legislation, but it's the throwaway remark, I think, sometimes that can cause problem. You forget you've ever said it, and the patient is left with it for the rest of their lives. So here's a plug for Peter and his team. This is the HSE National Healthcare Communication Program. Peter, I'm giving you a good pat on the back here. It's a national program to support healthcare staff to learn, develop, and maintain their communication skills with patients, their families, and with colleagues. I think I have to put a plug in, Peter, for my own branch of the profession, and which I am also a trainer. We are very conscious of communication skills with general practitioners, and they have to do video consultations during their training, at least on 3 occasions. And it's amazing how you learn your habits when you actually do video consultation. And I remember the first time I did it, it's like something when you watch it yourself, you want to watch it in private where nobody's looking at you in a dark room. But I did discover that I was picking my teeth with paper clips. So that was the first time I ever knew I did it. And nobody had ever said it to me, and no patient had ever said it to me. But I just took the paper clips off the desk after that. And that's about 15 or 20 years ago. So it's really a very good way of learning if you're communicating properly.
Sorry, Rita, do you want to?
Is that okay? Can you hear me? And is it any better that way?
That's better. Rita, please go ahead.
Okay, thank you. So, Peter, I was in the middle of lauding your program. It's underpinned by the core values of compassion, trust, and learning. And it builds on these values with a focus on person-centered and clinical communication skills. And it's very constructive. And the overall aim of the program is to improve the experience of patients and their relatives by supporting staff to take a sensitive and a person-centered approach in all conversations with patients and families. I think we need to remember that the doctor-patient relationship is never an equal one. We have the power in that situation, and we need to be really careful where the power lies. We also have a responsibility, as most of you know, in maintenance of professional competence. Postgraduate training bodies operate the professional competence schemes, and doctors must demonstrate, the training bodies must demonstrate that the CPD they offer incorporates the medical council's domains of good professional practice. And I'm just going to mention a few of the domains relating to patients. Good medical practice is a relationship of trust between doctors and society, and it's a partnership between doctor and patient. And in fact, it says they're patient and doctor. And I think that's what we have to realize, that we, again, I'm talking about the power in the relationship. We seem to have the power to the patient, and they're dependent on us for information and knowledge and professionalism. And so there has to be mutual respect. Confidentiality is absolutely vital. Honesty, as I said before, I would often say to relatives, no, I'm not going to tell your father or mother or loved one a mistruth. And responsibility and accountability, okay? Communication and interpersonal skills. Doctors must demonstrate effective interpersonal communication skills. And, you know, Atika, I hear your story about the culture, and I think you've got more Irishisms now than maybe you had previously. But, you know, Irish doctors are just as poor at communication. It's not a race issue. It is a part of not understanding that it is so important. And as they say, it's not what you say, it's how you say it that matters, okay? And sometimes it's a good idea to actually say to the patient, can you tell me what your understanding of this is? What did you hear? And often they've heard an awful lot different to what you actually thought you had said. So reflecting back is a very useful tool. And another one of our good domains is collaboration and teamwork. Practitioners must cooperate with colleagues and work effectively together. So the communication within healthcare teams is vital. And I hear from colleagues and from other people that sometimes this is not what it should be. And Mustafa knows that my daughter works with him in the ED department, and I hear stories about handovers between teams that would make anybody embarrassed. And I don't think that's unique to that hospital. I think sometimes the argument over the patient, whether the surgeon will take the patient or whether the medical side will take the patient, is less than professional. So I think we need to always remember our professionalism within teams as well as within with each other, as well as with patients. So it's not just doctor-patient relationship, it's doctor and team relationship, relating with the nurses, the OTs, whoever. Okay. So the way forward from our perspective, the council intends to reduce mandatory CPD in communication in the maintenance of professional competence framework model. Now, this is led to a little bit of irritation on part of the training bodies, but our future CPD model will probably look something like that. In every 5-year cycle, 20% of it must be about communication, because people think that when they're in their 50s and 60s that they know how to do it, but in fact, they don't always. So it can always be improved. Many parts and relationships need to be got on board to implement this change. And as I said, the discussion with stakeholders, nobody likes mandatory, but if we're getting 20% of our complaints about communications, and if 20% of the CPD is about communication, 20% over 5 years is not a huge amount. So that's the way forward. This, the Medical Council's Guide to Conduct and Ethics, it's actually on the next slide. But this one here, Safe Start, are you a doctor who is new to medical practice in Ireland? This is a resource that we published about 3 years ago, I think, for doctors who are new to the practice of medicine in Ireland, and it includes essential information on consent, prescribing, end-of-life care, record keeping, and general conduct and communication skills. Oops. Okay, and this is our ethical guide. As I say, I have about half a dozen of these now around my house, but there's one under my pillow most of the time, because when I get asked questions, this is the little Bible that I refer to, and it's really a useful book. So it's I prefer the hard copy because I kind of know the parts now where I need to go under certain things, but it's there to support doctors, and also we stand behind doctors who advocate for reform, and also that those who speak out on behalf of vulnerable patients. We have a responsibility as doctors, when we see things not being as they should be, to actually speak out. And the doctor's first duty is always to put their patient first. And I frequently say to young doctors, put the patient at the front of your brain and you won't go far wrong. If you're advocating, put the patient first and you won't get into trouble with anyone, okay? The guidance on advocacy is in the guide, and this is 4.5. You should act as an advocate for your patients in two ways. You should speak on behalf of individual patients to help make sure they receive appropriate health care. But in addition, you should support all patients by promoting the fair distribution of limited resources and fair access to care. And I've got myself into trouble with a lot of colleagues by being openly an advocate for patients. I do not regret any of it, and I will continue as long as I'm alive to advocate for the fair distribution to patients. Patients should be seen on the basis of need and not on the ability to pay, would be my firm belief. If you're a doctor in a management role, you have a responsibility to advocate for appropriate healthcare resources and facilities if insufficient resources are affecting or may affect patient safety and quality of care. And I know a lot of hospital doctors are very afraid of this, but you do have an ethical responsibility. Telemedicine. Interestingly, when I started in this job, the very first talk that I gave, I was asked about telemedicine, and I set up a group within the council about telemedicine, a lot of good external members of it. And were we glad? We were halfway through the work, and COVID absolutely had to accelerate the work. So the impact of COVID has meant that telemedicine has become an integral part of medicine. I'm continually amused at how long a letter I can get from a consultant who's had a teleconference or a telephone call with a patient. The letter that they write is often longer than the one when they see the patient in the clinic. So it's an interesting facet of it. Telemedicine can help patients who are vulnerable receive necessary care. More convenient for the patient. And it depends on the patient. You can use video with the younger patients. The older patients, in my experience, don't really particularly like video conferencing, but they're well able to manage a telephone consult. It's particularly useful when it says when it's part of an existing system. It's particularly useful when you know the patient, okay? And it's more difficult, I would think, for hospital doctors than for general practitioners, because you don't see the patients as often as we do and don't have the long-term relationship. But it's really useful if you actually know the patient that you're talking to. So new ways of delivering care and a different communications approach may be needed. And so this is the guide, and it's available on our website. Finally, I just want to say something about bullying. The headline is right. Bullying is unacceptable. Medical Council has a zero tolerance approach to bullying at all career levels among registered medical practitioners. We have a lot of information on bullying, and it mostly it's the first people to bully doctors are other doctors, and the next people are nurses and other healthcare. But the nurses and the doctors tend to bully each other. If you see some bullying, then you have to try and sort it. And I would encourage you to. If it can't be resolved at a local level, then come and talk to us and we can deal with it. And I can give you some examples of how we might deal with that. We monitor the situation in relation to bullying as part of our regular clinic site inspections and also in our research, particularly with trainees and your training counts. And the council is working with our stakeholders to examine programs currently in place to deal with bullying. So thank you. I'm happy to take any questions from you. And I hope this is a little bit of use to you. Thank you very much.
Thank you very much, Dr. Doyle, for the wonderful presentation and lots of words of wisdom. There are a few questions, very interesting questions from the audience. And the first question that I have for the panel is that if the patient is a minor, and the parent, the father or the mother, does not want the patient to know of their diagnosis or wants to hide the bad news, where do we stand as their primary physicians?
You can. Well, I think from my perspective, I would say that if the child is underage, then the parent is responsible, and that's the parent's decision. If the child is age of medical, access to medical care, then that's a different situation. Okay, but if it's a child, then it is the parent's decision and not the doctor's decision. You can advise the parent and support them, but you cannot go against them.
Thank you very much. A question that COVID or the last year, we have seen a massive change in the way we communicate. We break bad news. We do a lot of things dealing with an angry relative. So just for the panel in general, how do you break a bad news over the phone? For me, it's often when I was running a cardiac arrest the last year, 5 minutes before ending the cardiac arrest or making the decision that I'm going to stop the cardiac arrest, I would go to the family, give them a cup of tea, hold their hands, tell them what's been going on. And it was an easier process and sometimes I would even bring them into the resuscitation room to see what was happening. But with COVID, things have changed so much, and it's a big barrier for all of us. So how do the panel approaches breaking a bad news or an angry relative over the phone?
Am I okay just to give a few points here? So I think over the phone, obviously the additional barrier physically, and you can't see the patient. So the big challenge is not having that visual information that would give you a lot of clues about the patient. I think it comes back to really emphasising the key communication skills that we've talked about. So Atika, Peter and Rita and myself have all talked about active listening and actually how important that is. And I think we really need to emphasise that really, really carefully. Ensuring that when we're breaking bad news over the phone, that we're really listening out for the emotion, reflecting that back to show that we've understood, taking our time very carefully. So those skills of listening, asking, taking our time, like the driving on ice, is really applicable here when we can't see the patient in front of us, and making sure that we're offering that support as much as we can for alternative means. Atika.
Yeah, thanks. We are still working with the original guidance from the HSC that don't break bad news on the phone at all. But then we have, my team is quite geared up to do video consults, and I believe, Attend Anywhere platform is available. Why we need to break bad news is because we run a memory clinic service and we often reach diagnosis of dementia. And it has to be, like these patients who attend the memory clinic, of course, are at a very sort of early diagnostic stage and understand the implications of the diagnosis. So we've had to make adjustments. We would just strictly do it on video. I have been caught out a couple of times where the video didn't work, and I just got consent from both, made sure that the patient wasn't alone, somebody was with them. And then just proceeded with both, their permissions and just explaining that normally I wouldn't be doing this on the phone. So there is a telehealth lead in every area available. If you just look them up, or you can ask HSC, virtual health support, and they will set you up then on one of those video platforms if you're not already. I would suggest that if it is a regular part of your practice, and if it is such a situation where there is time, you can afford time to kind of talk and give a day, before you break the bad news, I think try to do this visually as much as possible.
Thank you very much. There is another question that general practice is taking place in Ireland is being taken over by large companies. This business has got a lot of time constraints and they see patients every 10 minutes. How does the medical council see these quick consultations? And are you happy, Dr. Doyle and Dr. Koo, with these quick consultations, these 5-7 minute video consultations, particularly when patients might have language barriers as well?
Well, I'm not going to discuss the corporatization of general practice. That's not my job. But it's really quite funny, Sarah, when an NHS patient comes to Ireland, they're used to a 7.5 minute consultation and I'm used to a 15. And so I'm only halfway through my consultation when they're getting up and leaving the room. So it's actually not the length of the consultation that matters, it's the quality. And sometimes you can do something in 10 minutes. Sometimes you can do something in 5 minutes, and sometimes it may take you 20 minutes. And when I started in practice all those hundreds of years ago, it was 10-minute consultations. And I learned about 15 years into it that this was not the way forward for me as a practitioner. And so I switched to 15-minute consultations. And of course, you have to fit in the extra like anybody else does. But it's, as I said, the emphasis has to be on the quality, not on the quantity, I think. And as I said, I'm not going to comment on corporatization.
Thank you very much. Next question that we have is probably Dr. Gillen and Dr. Khan, Dr. Mukhtar, you might be able to answer that better. When consenting for a surgical procedure, should all the complications of the procedure be explained to the patient in detail?
Well, I think there's good guidelines about consent, though I don't think we'll ever get the perfect consent because you can always really be caught out. I think the guidelines are pretty clear that we need to outline common complications and uncommon complications, which are life-changing should they occur. So there are very common ones associated with any operation, and we would have to go over those. But things like common bile duct injuries, for example, during cholecystectomy, although the incidence is very low, 1 in 1,000 perhaps, because it's a life-changing incident, you do have to inform somebody about that. So I don't want to get into consent today. It's a total area in itself, really. But certainly, I would think that diagrams are very helpful. Leaflets are also very informative to give patients to go away and read up, because each operation should have in each hospital a standardized information leaflet for patients. Could I just go back on one thing that Atika said as well about telemedicine? I think it's really taken off in COVID. And we, in the RCSI, we produced a very good link for tele and video consultations, which is available free on M-Surgery. So if you log on to msurgery.ie from the RCSI, it's a free resource. You can get CPD points from it at the end as well, and they're excellent. Could I just say as well that Attend Anywhere, public purchased by the HSE, but actually most of their information about it is on the technical end of how to use it. So I would counsel that people do need communication skills training in order to use Attend Anywhere, as well as the technical ability to do so. Thank you.
Thank you very much. Rachel Lynch is here with us. She's the business lead for MPS Ireland. Rachel, over to you.
Thank you. Thank you. I just want to say a very quick thank you for inviting me along, and I will be very quick because I'm conscious it is very close to wrap up time and you may well have more questions at the end of this. As said, my name is Rachel Lynch and I'm the business lead for Medical Protection Society. I work alongside Dr. Sarah Coop, who you heard speak to you earlier this morning, and she's in our risk prevention department. All I want to do today is talk to you very briefly a little bit about who MPS are, what we do and what we provide, and why it's vitally important, and particularly working in Ireland, that you are a member of a medical defence organisation outside of what you get under the clinical indemnity scheme in the hospitals. Sarah, if you can, thank you. Like I said, we're a medical defence organisation and we were established 125 years ago by a group of doctors. We are a Doctors for Doctors and a Dentists for Dentists organisation. That's always been our ethos. We have 300,000 members around the world. We have offices in Hong Kong, Malaysia, Singapore, New Zealand, South Africa, UK, and Ireland. And we have 16,000 members in Ireland, and that's made up of NCHDs, consultants, GPs, dentists, and other healthcare professionals. Thanks, Sarah. We have a very different ethos to the likes of insurance companies that work in this med-mal area. We're here in a threefold capacity. So we're here for members before complaints actually arise. And that's the department that Sarah works in. We do an awful lot in risk prevention and risk management and trying to stop claims and complaints from occurring in the first place. And then we're here for you if a claim or complaint is brought against you, which is not something as doctors I'm sure you like to think about, but unfortunately it does happen. And then we're here for you the whole way along through the process of that complaint. This slide is probably what's most important to those of you who work in public hospitals, either at consultant or NCHD level. You will all be aware that there is a clinical indemnity scheme in Ireland run by the State Claims Agency. And effectively what the clinical indemnity scheme means is that no patient will go uncompensated in a public hospital in Ireland as a result of an adverse incident. The clinical indemnity scheme ensures that that piece of compensation that's paid to a public patient is paid by the clinical indemnity scheme. So where MPS fits in for those public hospital doctors is for the likes of your regulatory assistance, for legal advice and assistance, for the cost in preparing for fitness to practice inquiries. We're there for telephone advice. We're there to help you answer the response letters from patients or solicitors, or indeed from medical counsel letters that you might get. We're there to help you with Garda inquiries, disciplinary hearings, anything else that sits outside of the actual piece of compensation that's paid to a patient is where MPS fits in for doctors. As you've heard earlier from Rita, there are numbers of complaints that do go through the council, and I have a statistic here, and Rita might give me a slightly more up-to-date one, but in 2017, 356 doctors were subject to a complaint, which was a 16% increase on 3 years prior to that. So 1 in 64 doctors in the register are likely to have a complaint of some sort made against them. And this is why having membership of a defence organisation such as MPS is vitally important. So what do we offer? We offer what's known as occurrence-based protection, meaning as long as you were a member, the day that adverse incident occurred, you are covered and protected regardless of what your personal circumstances might be. So you might have left membership, you might have returned back to another country, you might have returned to work somewhere else. As long as you were a member of MPS when that adverse incident occurred, you're protected for that adverse incident and any of the ramifications for that. So again, these are some of the things and some of the supports that MPS offer. We're here for claims. So those of you who need claims indemnity, the indemnity is there for anything arising from your clinical practice. The legal issues, which I've touched on, so that's the advice, the legal representation, medical matters, medical counsel matters, disciplinary proceedings, etc., criminal investigations and complaints. It's very important. We have a 24-hour advice line, and that advice line is manned by a doctor who's legally trained. And we can give you advice and open a case file if needed at any point during the day. And of course, particularly when you're working in a country as small as Ireland, we do a lot with the media and handle assistance and advice with regard to reputational damage. As I mentioned, and as you've seen Sarah present earlier, a huge amount of the ethos in what MPS do is to provide some risk management and risk prevention before you get to a point of a claim or a complaint being brought about. The Risk Prevention Department was established 8-9 years ago, and it's one of the key important directions of travel for MPS. We have webinars, we have podcasts. We've just launched a rather large digital health telemed series, and there are some of this that's actually available without having to be a member. So you can log on to the MPS website and you can have a look at some of the resources that we have in risk prevention. We also have face-to-face workshops when we get back to being able to present in a face-to-face capacity. They're run in Dublin and Cork and Galway. We can run some of them in-house and collaborate with the likes of the RCSI, the RCPI, and indeed the ICGP to deliver some of our risk prevention and risk management. So I would, if nothing else, I would encourage you to log on to the MPS website and have a little look around the risk prevention offerings for doctors and just get a feel for what it is that we actually do for clinicians. We'd run masterclasses on particularly different specialties as well. Sorry, Sarah. Thank you. So how much does it cost to be a member of MPS? So for NCHDs working in public hospitals, and again, these are just indicative prices. You would have to go into the website and just complete a very quick online application form to be able to get the correct price. But this is indicative. And again, it's just to give you an approximate idea, depending on where you think you might be in terms of, obviously, interns, first year qualified, but most of you will sit at 7 years post-qualification registrar or specialist registrar. And again, if it's consultant level, it will just depend on the specialty that you're in, but I'll be able to give some pricing based on that. I just wanted to give you some indicative prices for NCHDs. And just, I suppose, to give you sort of a real life example, and this was one I'd spoken to Peter about a number of weeks ago. A lot of doctors who approach me who think they have enough cover under the clinical indemnity scheme don't actually realise that financially you can get yourself into a lot of bother in terms of having to seek your own legal assistance and advice if a claim or complaint arises. So we had quite a high profile case in Ireland about 6 or 7 years ago. And a doctor approached us who didn't have MPS membership and was involved in the care of this patient who had gone on to die, unfortunately. And while this doctor wasn't directly involved with the case, they were involved in the care of the patient. So they had to get their own legal assistance with regard to the case. And after 3 years, I think their legal fees had amounted to about €72,000. So that's just, and I don't want to say that in any way to scare any of you, but it's really just to bring to light how expensive some of these legal fees can amount to when you're caught up in a claim or complaint in Ireland. And none of that is handled under the clinical indemnity scheme. Like I said, the ethos of the CIS is there to ensure that no patient goes uncompensated. So that's the cover you get under the CIS scheme. MPS handles everything else outside of that for doctors. Sarah, thanks very much. Just contact details, guys. And if you log on to the medical protection website, for those of you who may not be members, you can log on there and you can actually apply for membership via the website, or you can contact the 1800 number, or again, my email address is there, and I'm more than happy to speak to anybody and any potential members or any current members. But I would strongly recommend, without wanting to sound like I'm doing a sales pitch, I would strongly recommend that if you don't have membership of a medical defence organisation, that you strongly consider doing so. Thank you. I promised I'd be quick.
Thanks very much, Rachel. Sorry, I'm just interrupting. I forgot, and I think now we are coming to the ending session. I would like to say thanks, which I forgot in my talk, to some organizations which help. Definitely Royal College of Surgeons for providing CPD points, and our sister organization UK, APPNE, and organization of Sudanese doctors and Libyan doctors, and other organization, and all the team from which this work has happened. Anyway, formal thanks will be done by Dr. Mukhtar in the end. We'll go back to the sessions. We were. Thanks.
Thank you very much, Rachel, for the wonderful talk. So one question that's for you specifically is, will MPS cover after the retirement of the doctor for his work when he was a member of MPS?
Absolutely. And that's one of the benefits of what I had mentioned about occurrence-based indemnity, meaning as long as you were a member, that carries through right on to retirement, and indeed after you pass away and your estate is covered then too.
One more question again. What exactly does MPS cover for if a legal case arises?
Just put your first slide back up again, Rachel. Start again.
I guess effectively it depends. If you're a doctor working in a public hospital, you're covered under the clinical indemnity scheme for that work that you do. So the financial consequences of that claim is paid for under the CIS. MPS does everything else. So we do all your legal representation, medical counsel inquiries, anything to do with the regulator, that gets covered by MPS. If you're in any level of private practice, that's when MPS also covers that claim. So the claim element of anything that's done in private practice, or indeed GP or dental practice, it's the claim and the non-claim that's covered. Whereas the nuanced bit is if you're in a public hospital and you're a public hospital doctor, it's we call it non-claims indemnity or non-indemnity, and that's what's covered for public doctors. Rita?
Yeah, can I just say, Rachel, sitting in the medical council, I'm not on fitness practice hearings, but we do have sanction hearings and the like. And when I see doctors unrepresented, they're at a very big disadvantage. And the reason it's a disadvantage, it's that it's difficult. It's a very legalistic procedure. And if you're a doctor, you're ignorant usually of that type of thing. And just to have the support of an indemnifier is just so important. And I would particularly speak to the younger doctors, because they arrive in this country and they don't realize this from the very beginning, that, they may have no case to answer, but if they have no support, it's really very difficult. So I would, I'm not selling your wares, right, Rachel? There are other indemnifiers, but what I would say was take out the extra indemnity for the small amount of money that it costs in comparison to what it could cost, but not just the money, just the emotional support. When I see doctors unsupported, it's just heartbreaking. It really is. So I would plead with you to look at that.
Absolutely.
Definitely. I'll just for practical purpose, I know I'm taking a lot of time, but this happened to me practically, and for my juniors for experience, I went out as say Aga Khan, I got a job and I went off to country and I stopped my medical indemnity. When I came back and joined, I was delayed in starting, and I sent, and you had changed some, setup to send the actual form rather on the phone. And during that, a complaint came, and you believe me, Rita and Rachel are 100% right. That was a nightmare for me. And I had to spend a fortune on just writing a legal letter to medical counsel. In thousands, I had to pay for that letter and the stress I was in. So I think it's not the money, it's the support is more important. Again, I'm not selling any insurance here. I'm not part of anybody.
Indeed. And it's something that you don't want to think about. You don't want to think about having a complaint made against you. You don't want to think about having a claim brought against you. It's not a nice thing to think of as a doctor. You're out there to do your best for your patients. But it is a reality of the environment that we work in, unfortunately. These things happen, and we see it in NPS more than anybody else.
Just one more question. Private patients treated in a public hospital, are they covered by clinical indemnity scheme?
Yes, in most incidents, they are covered by the CIS. Yeah.
Okay. And another question, an interesting question for the panel in general, that most of the times we are bound by limited availability of time to console or satisfy the patients, and their expectations are endless. How do people deal with that?
Yeah, I mean, the patient's expectations are endless, but so are ours. We just have to balance it. We want to do the best. We don't always have the time to do everything we'd like to do. So doing something is better than doing nothing.
I think we are at the end of all the questions that we have received. Thank you very much. If there are any more questions from the participants, please send them now. Are there any more questions?
I think if we are on the time, you can just invite Dr. Mukhtar to formally close, and in the meantime, they can chat box answer the questions there.
Dr. Mukhtar, over to you. Thank you very much.
Okay. On the behalf of Irish Pakistani Professionals Association, IPA, I want to say special thanks to all the participants, starting from the Prof. Peter Gillen, RCSI, Dr. Rita Doyle, Irish Medical Council, Dr. Atika Rafiq, consultant psychiatrist, and Dr. Sarah Coop from the MPS, and Ms. Rachel Lynch from the MPS. Last but not the least, the special moderators, Dr. Mustafa Ahmed, fellow in the ANE, and Dr. Adil Zafar, SPR in the vascular surgery. And working in Ireland from last more than 25 years. And to be honest, a lot of learning for me after listening. It's not only the presentation. I think a lot of credit goes to the people who contributed, especially on Saturday, and not only Saturday today, but a couple of weeks, in the practice session, organizing and delivering. It was not possible with the help and commitment from all of you guys, and a lot of people who are the backbone, like IT specialists, which is Asif Sayed and Khalid Abbas. And I will say that we try to make it as interactive as possible. Apart from hearing the voice of the audience, we put all the questions. I was close watching, and my main role was just to keep eye on how the things were going. And I think we try to put all the questions. It's very difficult to answer all the questions to our session. As long as we can understand what our aim was, what from the legislative point of view, from the medical council, and from the college point of view, different people, and from the work experience from the different specialty. So I think our email is there. If people have more questions, they can put to us, and we can try to answer as much as possible. Thanks all. Thanks for the participants. Thanks for the speakers. And thanks for the backbone IT people. Thank you.
Thank you very much.
And thanks, everybody has done the feedback form. So when the meeting will close, you might not have access. If you want, we can leave the meeting running for 5 minutes, mute the mic, turn off your cameras, and people can still access the feedback form. So by formally we saying bye-bye now. Thank you.
Thank you very much.
Thank you.